So yesterday you had released a very, very important document, position statement for the management of STEMI. STEMI burden is huge in India. So through this position statement, what is the message, sir, we are giving to the physicians who are mostly the first point of contact for most of the myocardial infarction patients, sir?
Before that, I think what is the purpose of doing this thing, that needs to be explained.
Yes, sir.
Till date, we always followed the Western guidelines.
Yes, sir.
And there are a lot of differences in the ground reality, what is happening here in India and in the West.
US or Europe, true.
Our STEMI burden is more. 60% of our ACS patients have STEMI, while this is less than 40% in the Western literature. Majority of the patients, they live in the rural areas where they practically do not get any form of reperfusion, leave aside primary PCI.
True.
So what should be done in the Indian perspective, that was the purpose of going through this, for formulating this position statement. We did it on behalf of the Guidelines Committee of the Cardiological Society of India. I happen to be the chairman of that committee. We involved all the experts. Practically all the important persons of India who is working in this field, they are involved with this.
What was the number of people involved?
Number of people involved, if you want to see, I can tell you that, show you the names. So they are all authors and reviewers.
More than 25-30 people. More than
this
that.
Is much more.
Much more than
much
that.
More. This is the writing committee.
Right, sir.
Basically, this is a writing committee. This is all these authors and reviewers, and the entire executive committee who are not there in the writing committee.
Okay.
They went through this document, gave their suggestions, and after that only we printed this.
So it's been thoroughly discussed.
It has been thoroughly discussed. We had 3 separate meetings.
Yes, sir.
Where each line by line, this document has been read out. Though I agree there will be some grammatical errors and other things, but this will be again correcting those things, and this will be published as a supplement issue of Indian Heart Journal in the January-February issue.
Very good. So this will be a guiding document. Probably
this is a document what a physician should do if they are encountered with a patient of STEMI in India.
Because till now we only had European and American guidelines, and
we
Indian
in fact segregated it into 3 compartments.
Yes, sir.
Because that is the ground reality in India. Some people live in metros or big cities where you have a number of PCI capable centers. Another section lives in smaller towns where perhaps thrombolysis is what can be done, and PCI capable centers are not nearby. And a very large portion, more than 50% of India lives in places where this is unthinkable.
True, very true.
So for them, we have given the guideline what should be done for each section. For the village people, what we say in the rural areas, go to the nearest hospital where a thrombolysis can be done.
Correct.
Do a thrombolysis, forget about primary PCI, forget about anything else. If it is possible to transfer, in that case go for a pharmacoinvasive, otherwise that may let it be a destination therapy.
Okay.
At least they are getting some form of treatment.
Reperfusion, yeah.
In smaller towns, what we have suggested is do a thrombolysis first, then try to shift the patient to a bigger city where a PCI capable center is there for a pharmacoinvasive therapy.
Right, sir.
And for the metros, either go for a primary PCI if it is possible. Otherwise, often in metros also it is not possible. Lab is busy, in the road conditions are bad. There are many reasons why one may not be able to reach the hospital soon or fast. For them also our suggestion is do a thrombolysis, then go for a pharmacoinvasive therapy within 3 to 24 hours after thrombolysis. So we have dealt with these things very meticulously and elaborately in this particular document.
So the major crux, what I understand, is pharmacoinvasive is
we are putting a lot of emphasis on that.
Pharmacoinvasive
that
approach.
is perhaps going to be the major area of our thrust.
Have we also talked about the thrombolytic agent which should be used or which should not be?
Yeah, definitely. No question of should be used. The ground reality is different.
True.
Recently we had some data from Tamil Nadu STEMI project,
Right, sir.
where they have mentioned that in the it is not a published data, it is a personal communication with one of the authors.
Okay.
They said in the tune of 94 to 96% cases they use streptokinase.
Okay.
In some places the use of tenecteplase is going up. What we say is tenecteplase has some advantages, definitely,
Right.
but it is costly.
Correct.
So it depends on first cost factor, clinical factors. Say a person is reaching 10 hours after an infarct, there is no point giving him tenecteplase,
Right.
because he don't have any advantage over streptokinase in that scenario.
True. Very true.
And thirdly, the choice of the patient and the doctor, which often we forget. We need to discuss it with the patient or his relations, telling them everything, what are the advantages, disadvantages, cost, and let them ask for their thrombolysis,
True.
thrombolytic agent.
So when is we planning to make it publish and making open to all the physicians across the country, sir?
That's what I said. In January, February issue of Indian Heart Journal, this will go as a supplement. But this doesn't have any statutory.
So it will not be endorsed by Cardiological Society? Or?
It is Cardiological Society's document, but government has not endorsed it. Okay. This is in the form of a recommendation we are sending it.
Are we planning to get any recommendations from government as well, or?
We'll be submitting it. Let us publish it first.
Yes, sir.
Then we'll send it to the government for their endorsement if they like.
True. I think, but that's a very, very relevant step which the society has taken. The burden
This is the
of
maiden attempt on the part of the Cardiological Society of India in this regard, and we are planning to come out with some other position statements in major areas of interest.
True, because as you correctly said, the ground realities in India are absolutely different.
It is totally different.
And it is very, very wise for us to take clues from those realities and make guidelines which are possible to do in India.
This is India-centric.
This is
entirely India-centric. That
True,
is what
true,
we are
true.
interested.
And I think this will definitely go a long way in saving a lot of important human lives. Thank you, sir. Thanks
Thank
a
you
lot
very
for
much.
joining, and thanks for sharing with us your views. Who are mostly the first point of contact for most of the myocardial infarction patients, sir?
Before that, I think what is the purpose of doing this thing, that needs to be